This material is for reference and educational purposes only. SimKit, its authors, and associates assume no responsibility for the utilization of any knowledge, materials, or techniques shown or described, nor do SimKit, its authors, or associates assume any responsibility for patient safety or outcomes. Clinical experience as well as current guidelines should determine the exact procedure and processes in each individual patient.
Hello, everybody, and welcome back. Welcome back to SimKit Podcast. Today, we're discussing a very interesting topic, I think globally in emergency medicine, but certainly for me. And it's really lovely for me when we get to incorporate some prior podcasts into our current discussions. And so for those who have been a listener to SimKit for a while or for a long time, they should know or note that we have done education on nasal fiber optic intubation in the past. And we will obviously have a link in the show notes to that podcast, which kind of talks about the setup, the kind of mental frameworks, a little bit about the execution of fiber optics, and me and a buddy putting some of that stuff down each other's noses and taking a look at our vocal cords. But today, I'm excited to say that we have a case-based discussion related to nasal fiber optic intubation with pearls and pitfalls in general, but also specifically for that case. So to have that discussion, I'm very excited to bring a new voice to the podcast, and Dr. Brett Johnson. He's a colleague of mine who was the primary care team member or provider for the individual we're going to be discussing today. So Dr. Johnson, thank you for joining us on the podcast, and tell the listeners just a little bit about yourself.
Yeah, thank you so much for having me. I would say that my background in fiber optic training is very limited. I am UMass trained. I'm out of fellowship and residency now for a few years. I did a fellowship in toxicology, but I practice primarily in the community setting now. And where I trained, we were really not taught a whole lot with fiber optic intubation. There was the occasional nasopharyngoscopy to look at cords and sort of posterior oropharynx for swelling. But really, as far as intubation goes, we didn't have any real formal training. And it wasn't until really after I left that they started doing more cadaver and sim-based training with fiber optics. So when this patient presented himself to me, I was certainly, it was a scary moment for me. But I think having all the colleagues around, as we'll obviously discuss, was very important. And certainly there's so many lessons in this case for people that have been out for a while and new people as well. So I think it's a great topic to talk about today.
Yeah, no, agreed. And thank you again for joining and kind of having our little ping pong ball type conversation. So UMass based toxicology fellowship, I believe your area of interest, which we'll maybe have you on for someday in the future, is poisonous algae. Am I correct in that, Dr. Johnson?
Yeah,
Something like that?
So definitely not related to intubation, although in our cases, I think they do intubate some bad shellfish poisonings and stuff like that. But yes, harmful algal blooms and the toxins they produce in public health is my area of passionate expertise, and things that I do out of clinical work is research in that realm. So
fantastic. I'm hoping someday we can get it. And I'm curious what the viewership would be on that topic, because it's niche. It is niche, my friend, but you are a practicing emergency medicine physician, obviously, in the same practice environment as me, the kind of, I call us academic, a community academic hybrid, because we have certainly education, but we are a community hospital, and we were working together on a case. So that's what we're going to kind of dive right into today. So my plan is to have us kind of review the case in sort of discussing each other's or our own clinical roles, and then kind of a live debrief of sorts, talking about the things that we learned to help our listeners care for these definitely challenging case types better than we did, if possible. I think we did a pretty darn good job, but we'll talk about it. But yeah, take some teaching points, some takeaways to the listenership. How's that sound, Dr. Johnson?
that sounds great.
Awesome. All right. So with that in mind, Brett, why don't you start us off kind of where, as you were the initial doc taking care of the individual, tell us a little bit about the setup, right? The background, the past medical history, and then lead us into sort of your initial kind of like from the door assessment on the patient.
Sure. So this was kind of like winding down for me at the end, sort of the tail end of my shift. And I think the guy was roomed as an ESI for shortness of breath or something like that. And So, I put my name on it, and we were working in our community hospital, but not our standalone community hospital. So we're in sort of this academic light medical center where we do have some resources available to us if need be. We have an anesthesiologist that sometimes is in-house, sometimes is a phone call away and a drive away. But there are other docs working on the shift with me. So I was by no means alone when this guy rolled through the door. But I remember going into the room and kind of helping, seeing the guy from the back actually, and helping the tech move the patient over from the wheelchair to the stretcher. And when he turned around and I saw his face, I immediately knew we were in the wrong room. We were just in one of our standard patient rooms. And this guy was drooling. He was tachypnic, and his tongue was protruding out of his neck about protruding out of his mouth 3 or 4 centimeters to the point where he could not open his mouth at all. So immediately I remember thinking to myself, we got to get this guy into the resuscitation bay. And the swelling that was coming from his tongue was pretty characteristic of angioedema. There was really nothing else that would cause that. And so we were very quickly able to redirect the guy back to our resuscitation bay. And as we were wheeling by our charge nurse area, one of the other providers just kind of poked his head up and looked, and I think immediately called anesthesia at that point to get them sort of mobilized and coming down to the bedside. And so we got the patient back into the triage or into the resuscitation bay, got him on the monitor. I think the biggest thing for me was keeping him in a position of comfort and not laying him flat. He was still awake and was actually able to kind of mime things to us. He couldn't speak. He couldn't give us a history. And from the triage note, he had just been dropped off by a friend. So I quickly glanced at his registration. He had his name, his past medical history, and nowhere there was an ACE inhibitor, and nowhere there was a history of angioedema. And so we had this guy sitting in front of us, in extremis, drooling, tachypnic, and with a kind of an emergent airway.
Yeah, that's a great lead in. I love the level 4 shortness of breath, which is just classic, obviously. I remember the shift, and I appreciate that we were, sort of pre-surge. Often we get our winter surge, and we had more space than might be occurring currently. So the ability to get the person back into a room relatively quickly is great. I also just, kind of facepalm that old idea of just you seeing the back of the individual. It's like those old cartoons where someone turns around and they look completely different than you imagine they might from their silhouette or their backside. But a person that's turning around, you're saying hello, introducing yourself, and you see this tongue basically occupying the entire oral pharynx, and immediately recognize that you are having a conversation with this person in the wrong room. It really shouldn't be a conversation to be had. You need to move them up rapidly to a higher acuity space. So 2 kind of like classic emergency medicine elements of that triage process and starting in the room. But you're describing to me pretty clearly here that someone that does not have a huge amount of diagnostic dilemma, and we might get into a little bit of the details of root cause. That certainly comes in when you're talking about angioedema, but we can quickly get down to a diagnosis of angioedema from what we'll have to see. But right, we were not talking about chasing rare diagnoses or working through a crazy workup. What I really want to hear more about is your degree of concern and how you started thinking in a stepwise approach about how you're going to manage this individual, and particularly this individual's airway.
Yeah. So I think, whenever you see a patient that comes in that looks like that, angioedema is at play, and you may or may not know their history of whether they have hereditary angioedema, whether maybe you have the luxury of opening their chart and seeing if they're on an ACE inhibitor, or maybe you don't even have any information about the nut allergy that the cookie that they ate 15 minutes ago, or the bee that stung them. So I think in the back of my mind, I'm always thinking like, am I going to give this person epi? And, am I going to go down this sort of anaphylaxis work pathway? Or is this more of a just kind of angioedema undifferentiated? We need to like either secure an airway or not, and then decide on treatment and medications. And I think pretty quickly we were able, whether it was through vital signs or no urticaria or two system involvement, kind of decide that this wasn't a guy that needed like epinephrine and sort of that anaphylaxis work pathway. Mm-hmm. And so I think immediately it became a matter of how quickly we needed to secure this airway and sort of what were the management strategies going to be. And fortunately for us, I think he wasn't in extremis to the point where he didn't have hypoxia. He was definitely drooling and questionably not protecting, he was protecting his airway, but I don't think he was really managing his secretions very well. His tongue was so swollen, you could not fit anything in the oropharynx. It was, and whether this was all anterior or there was going to be posterior involvement, it seemed pretty evident to me just based on how he looked that whatever sort of airway intervention we were going to be attempting, we were going to be looking through the nasopharynx, at least initially. So I think sort of my stepwise approach in these situations is one, keeping them in a position of comfort if we have this time, not aggressively moving to some sort of a maneuver where you're going to lay them flat and they're going to become hypoxic, get into an extremis or a rush situation where we are going to have to move faster than we already are. And so I think having the other providers around to kind of almost immediately assign roles and sort of assign a stepwise sort of plan of action as far as how we were going to manage this airway was very important. And I think in this situation in particular, it's moving fast, but moving very deliberate with what you're going to attempt. And then if that doesn't work, what is your backup going to be? And in this case too, who is your backup going to be? So probably one of the biggest things or takeaways from this case for me is just knowing sort of in the practice environment you're in at that time, what resources you have. So I know both of you and I do time at other academic places. And, in some instances that's calling, the code airway protocol team, whether that's, an experienced anesthesiologist coming to the bedside or surgery for a surgical airway, or at least having them on backup. In this case, I think having anesthesia, or at least anesthesia, be aware that we had this critically ill patient that was sick and was going to need a definitive airway on their way. They definitely do more bronchoscopies, more fiber optic intubations than we ever will in the emergency department. And so having that expertise, at least on the way, I think was also important. So
I like that approach and breakdown globally of kind of like two things that in my mind, and I might be mistaken here because you were kind of the medical lead in this, were running concurrently. You're going to think and try to address root cause, and you're going to take the life threat out as best you can, quickly, but smoothly, as you said. So airway management and treatment of underlying condition. And, we've all seen anaphylaxis and bad anaphylaxis where that intramuscular IV epi is the thing that is going to try to prevent both, right? Where they're wheezing, they're covered in hives, they're tachycardic, hypotensive, and they're peri-arrest. And epi is going to be the thing that saves that person. This person with oropharyngeal angioedema, the airway management seems paramount. The epinephrine and potential treatment of those things can and should run concurrently, but your priority is what is basically an obstructive, pathology of the airway, right? And so I like that sort of thought about thinking of the two, recognizing that we're not in that category of like peri-arrest, anaphylaxis, epinephrine is the only thing that will save the life, and managing the airway and then moving into, as you did, who's going to be my backup? What is my approach? What are my thought processes there? I guess you had mentioned in the introduction, one of our other colleagues saw the face that was being brought back to the resus bay and said, call anesthesia. So we have anesthesia paged already, but tell me a little bit more, Dr. Johnson, about your sort of thought processes. You said the tongue was so swollen that nothing was going in the mouth. And then you're thinking about going through the nose. We obviously have the front of neck. Kind of break down where you were at in terms of your approach to getting these areas secured. And if I could, a step backward, did you recognize immediate need for intubation, or were we thinking maybe this is isolated tongue angioedema and the patient may not need airway procurement?
That's a great question. And I think it's somewhere in between, I think, is the answer to that. So we're in like this academic light institution where if we're going to admit to the ICU overnight, we're going to have to go up and intubate that patient overnight if their airway worsens. If we're going to have to transport a person to another tertiary center, they're going to have to, in this case, probably go by critical care, but there's going to be a question of whether we need to secure an airway before they would even be safe for transfer. So in the immediate moment, I think we all in the room recognized that we didn't need to do a crash airway. We didn't need to prep the neck and kind of jump on this guy and secure his airway. But that in order to determine how quickly we needed to secure an airway, we would have to get a look at that posterior oropharynx, at the cords, at those areas that we really can't see visually, and in this case, couldn't see at all. And so I think there was a very deliberate move to start prepping in sort of an upright fashion for us to be able to look through the nose at that posterior oropharynx and kind of decide how quickly did we need to secure the airway. I would say from a vital signs perspective, he had a pretty good oxygenation. He was slightly tachypnic. And I think our biggest barrier was that he was pretty secretional. And it's just because other than swallowing, there was no way for him to get any of those secretions out. So keeping him upright, keeping him in a position of comfort while we're setting up was incredibly important. Now, like I'd say that whole process, I've been involved in a couple of these airway situations, and I would say whenever that's sort of the call where it's like, we probably are going to have to intubate this patient, we do need to get a look at that posterior oropharynx, we're going to use a fiber optic to do that. I think my kind of gestalt in my training has always been, well, if you're going to stick a nasal fiber optic tube down the back of that patient's nasopharynx and taking a look, it better be loaded and you better be ready to be able to advance a tube and secure an airway, because that might be the only shot that you get. And so I think we were all kind of on the same page there, that if we were going to take a look, we were going to be ready to intubate this patient in some fashion if it was necessary.
Yep. That's kind of, I think, where I entered the fore. And so just correct me if I have false memories here, but I think our colleagues saw the case coming back. You went into the room with the patient. They asked for anesthesia. I don't know if that person had another critical process that they needed to be involved in. There's a short period of time, I'm assuming, during which you're, setting the patient up, keeping them upright, getting IV access. And then a call came to me to join in the resus bay. And so I entered the room seeing, obviously, the same you did, of a secretionist person with a tongue that occupied so much of the oral pharynx and protruded that they really couldn't move their jaw, right? There's almost no ability to even open or close. It was just fully open with the tongue coming outward. And I think early on, you had obviously established yourself as the primary care provider for the patient. So then the determination was, well, I can be the proceduralist while you do all the other elements of that. Is that how that transpired?
Yeah, that's exactly how that transpired. And I am so happy you were there, because as I mentioned, my fiber optic training is scant at best. And I've now worked in a few institutions where we have purchased and we now have fiber optic capabilities at the bedside for all intubations. And I'll say I'm definitely still in sort of the old school train of thought. And I think it's probably from my training background, where a lot of times I feel like in these emergent situations, we should be doing the procedures that we do best and we do most often, because we'll have the most success with them. And so to a flaw, I think I probably haven't been picking up that fiber optic scope enough and practicing and being prepared for situations like this. And this was sort of my wake up moment from a situational standpoint, that I do think we should be hands-on with these scopes every few months just to kind of maintain a muscle memory, because It is a skill, as I mentioned, we're not using as much as anesthesia or any of these other providers, but in the moment, we may be the only ones there with this tool at our disposal. And this is the perfect patient in the perfect case where this was really the only option other than a front of neck access procedure if we were going to secure an airway. And so I think having you there, having your expertise there, having us be able to divide up sort of who was going to take the procedure, who was going to stand back and run everything else that was occurring really helped, paid off a lot. And I think really contributed to such a successful outcome that we had. So,
yeah, couldn't agree more. I think that we're in a lucky position with our number of coverage. And I think you were on the winding down. Someone had recently just come on and I was in an in-between space, and we were able to have 2 dedicated doctors in the room at the same time. Not everyone can do that all the time. And so that's a blessing that we recognize that we had to have a proceduralist and a, foot of the bed general running the show. I'm going to sort of break down my setup for fiber optics, and then we can kind of get into the details and nuances of communication, getting the patient ready. There's a little, anesthesia wasn't just out there in the nether for forever, so we can talk about that. So I'm just going to start with when I recognize where we were and the need for the nasal approach. Part of it, Brett and I were sitting there and saying, this looks bad. We definitely need to see back there. We need to see if this angioedema involves the vallecula, if it involves the cords, what is it looking like? And if, as Brett said, if we're looking, we're ready to save it, right? We're ready to procure it or secure it. So I'm like, all right, I'm going to prep for nasal fiber optic, at least visualization, and then possibly intubation if the need is there. So for me, that is, we have the long swan neck, flexible wire. It's called the MAGIC, MADGIC atomizer. Take nothing from that company, but it's an atomizer that can actually go all the way back in the posterior nasopharyngeal space and atomize outward rather than just the cone, Narcan or midazolam atomizer that we often use. So I get the MAGIC atomizer and I ask for 4% topical lidocaine. That's what I like to use as the highest concentration we can to make this as comfortable for the patient as possible. So these were requested, and we'll talk about communication styles in a second. 4% topical lidocaine, MAGIC atomizer. Our bronchoscope, our flexible scope, is one that can be loaded with a endotracheal tube, obviously, and hooks up to the same video system as our standard VL device. So plugged into a port, gotten ready with the tube on it. I then also like to just have a wet, like a 4x4 that's just wet with water or saline, and a lubricated 4x4 for cleaning the camera and for lubricating for insertion. Some people will use viscous lidocaine. I find that finding that and getting that is another step further on top of my 4% topical lidocaine. So I just use regular lubricant. So that's my prep. I then find, if I can, have the patient close one nostril and breathe, close the other nostril and breathe. They point, if they can't talk, they point to the one that they felt like they could breathe out of better. And that's what I'm atomizing with my 4%. I like to go in and atomize on the way out and make sure that I get the very tip of the nostril. Because if you've ever had someone, flick you on the tip of your nose, it's very sensate, and that one can be uncomfortable. So I like to do that at least twice. If I can do it 3 times, all the better. If they can have it sit in the back, in their hypopharynx, let that sit there momentarily before swallowing, then even further improvement in anesthesia. So I believe for this individual, we got our 4% quickly. I knew where the MAGIC atomizer was. I was able to hop out of the room, get the couple supplies I needed, and had anesthetized the left nair of the individual, which was identified by that patient as the preferred one, and had atomized it twice. We were there and prepped with a tube on the the fiber optic scope, and anesthesia basically came in the room at that time. Is that right, Brett?
Yeah. I think we had anesthetized and we were really getting ready to go. I would say the only other thing I'd add to that is while all that was taking place, we were already thinking about kind of backup plans. So we had a bougie and a scalpel at the bedside. We had prepped the neck and kind of felt for landmarks. And so we had sort of a backup plan in place for if things went south quickly, what our next steps were. And we had identified who was going to do that as well.
Yeah, fantastic. Thank you for bringing that forward. Because as you mentioned, like you can't go, oh, now I'm going to try oral and see. There was no oral option in this individual. So front of neck cricothyrotomy was going to be our backup plan, basically. Brett, tell me. Oh, go ahead.
Oh, I was just going to say the only other thing I would add is, again, just how fortunate we were to have 3 people here is having me kind of as like the sort of head at the foot of the bed kind of watching things is where I have seen this go wrong is where, the person that's going to then decide to do the cric is also the proceduralist trying to do the fiber optic intubation. And once you get down and you're starting to work and actually like do the procedure, it's so hard. Time has a way of slipping by really fast. And so you don't realize how long you've been doing a procedure and knowing like when you actually need to abort, move on to the next step. And so having 3 providers there, I think was really important for that reason.
Yeah, that's a good point. That sort of line in the sand will move, especially when you're like, I think I could get it. I had the bougie through, but I can't get the tube. Let me try 3 other tube sizes and then hypoxic arrest. So yeah, good point in there. Having someone else keep the line in the sand for your failed airway algorithm is really nice. And yeah, luxury of many providers at that time. I think honestly, it could be a 2-provider system where if at that moment, if I can't get the fiber optic scope to work, you're transitioning to the proceduralist at front of neck and I step back and away. If we're thinking about our more resource limited settings or, in our freestanding ER, we'll have an APP in ourselves. So if we're trying to organize this and have it have the same degree of success with less people, I think that would also work. But that's a really important point of someone else moving you down the algorithm or the funnel or the failed airway, structure that you did. Brett, I was hoping if you would tell us a little bit about, we've anesthetized, we've gotten that patient comfortable from just getting a fiber optic scope through the nasopharynx, hypopharynx. But that's not the end all for someone that we're considering putting a breathing tube through their cords if we don't like what we see. So give me your thoughts about sedation, anxiolysis, and how you were going to move through this process as the primary provider of care.
Yeah. So as I mentioned, I think position in this case was really important. So keeping him upright in a position of comfort for a secretional standpoint and just for the positional why with his tongue being so big was important. So I think an upright approach, and I really wanted to keep him breathing on his own. And so ketamine was definitely our drug of choice. And I started with a mg per kg of ketamine. I wanted to dissociate him, but I wanted him to be breathing and potentially following commands if we needed him to. And I really wanted to get enough sedation on board that we could get a good look at what was going on in the back of the throat and then decide, are we going to push him deeper? Are we going to paralyze him? Are we going to intubate? All of that was going to be really, we had all the meds there. We were ready to give them, but we were going to wait and see what we saw before we made that decision.
I like that approach. And that was perfect for me as a proceduralist, a mg per kg, facilitating doing this uncomfortable work. But then, if you recognize your need in that hypopharynx, like, oh my God, the arytenoids look like garbage, the cords are swollen, we need to move further, then we can go deeper, right? We could go deeper, we can do paralytics, those types of things. So I liked that approach. And as the proceduralist, I think you sometimes have brain, obviously, to say your meds, like I'm going to be intubating, I'm going to pick my RSI meds, my DSI meds. But I think that we had just a really clean line of communication where I knew that patient was being prepped for a mg per kg of ketamine as I was doing the topical anesthesia, which I think gets into a really important point I want to get into. When you have 2 cooks, you have at least 2 cooks in this kitchen, right? It can start to come apart pretty quickly. So communication and that structure is really, really important when you have the person running the resus and the person doing the procedure. Closed loop communication with a single point for requests I think is the way to do it. Sometimes I've been in situations where it just naturally materializes that we have almost two parallel groups, right? The proceduralist, their nurse and tech, the resuscitationist, their nurse and tech, and that gets loud. It gets cross signals. I find it more challenging. It's hard to work in that way, but sometimes that's where things lie. I liked how we did it, I believe, where we basically had our most senior nurse as the point of echoance or the point of communication for both of us. When something was needed or a summary was needed to be done, we were looking at our lead nurse as the person with whom we're speaking. And we did pretty good closed loop. I don't think I used names each and every time, but I had eye contact where it was like, Brett and Sarah, I need a nasal fiber optic scope to the bedside now. So name of the person, what you want, timeline for it to be done. And then Sarah was able to direct that to, our tech. So say, Tech Tom, please go and get the nasal fiber optic scope now. And Tom is going to say, nasal fiber optic scope coming to the bedside now. When he comes back and it's there, nasal fiber optic scope at the bedside. I'm not going to say that we had that amount of closed loop communication, but I felt like we were pretty dialed in that way. We were both trying to get communication to a lead nurse who is then directing the task to either a nurse, a tech, or back to one of us as a proceduralist or the resuscitationist. So how did that structure feel for you? And in terms of that communication as the person I see as the general, I might be your next in command in terms of the proceduralist, but how did that feel in terms of your control of a pretty challenging room and a challenging case?
Yeah, I think you used the word natural, and it did feel very natural in this case in particular, which is fortunate. I think the early delineation of roles was helpful because I think the nurses then knew, they can come to me if they have the question initially, and it leaves sort of mental space for you to think about, procedurally what you're about to do, what you're doing. And so I think that worked out really well. And I think also, fortunately for us, anesthesia rolled through the door as we're just about ready to do all of this. And it was almost like a pause. We walked through our whole entire sort of plan and our backup plan, and anesthesia was just like, yeah, that all sounds good. No, they didn't. I don't think they ever felt like they needed to take the reins or anything. And certainly they were there if we needed them. But
yeah, I didn't even really think about that timing element, which did lead to almost like a timeout, right? Not necessarily that we would have to do. I mean, he had a level of airway control where a timeout probably is valuable and a nice thing to do in summation to make sure you're not missing that one little thing you need. But that individual came in the room. I remember having the bronchoscope, the nasal fiber optic scope in my hands at level, about to enter the nair when they came in the room. And so we just did, hey, this is where we are and this is what we're going to do. Are you okay with that? And they're like, yeah, seems like a good step forward. They were there with our blessing, or they were there to bless the process. And it definitely felt better for me, knowing that this is a rare procedure, to have them there in the background, to have them there to work with us if we run into any difficulties. But that was a nice opportunity to summarize before taking steps forward. And it was an interesting space for us where adrenaline's up, you're going, we're ready, we're about to do it. And then someone enters the fore and it can change the dynamic. Like, now who's in charge? I've had that with when trauma or someone else is entering a critical case. That dynamic can be challenging for sure. It wasn't in this case, as we had a seasoned anesthesiologist who felt like they had confidence in us. But thankfully, that wasn't a tripping point, which I think is something to highlight. When a new provider, particularly other specialists, enters the space, summary and redelineation of roles is super important.
Yeah, I totally agree. And I have definitely been privy to situations that don't go as smoothly as that did too. So you're absolutely right.
Yeah. All right. So I'm going to get into where I ended up. I guess my biggest learning point might be two, but so we paused, right? We were right about to go. We had a mg per kg of ketamine. We had you at the foot of the bed, me as a proceduralist. We had front and neck as our backup, and we had anesthesia in our pocket. Like, yes. How do you not succeed, right? But yeah, it's possible we don't. We move forward. We're going through the nair. I had loaded that 4% saline in the working, I believe it's called the working port of the fiber optic scope, got down through to the hypopharynx, definitely saw some edema, at the base of the tongue. Obviously the tongue itself is a monster. And we were looking with anesthesia. We got a good shot of the arytenoids and cords, and we saw what looked like some water bag type, right? You kind of get more of that in that really gushy area of the hypopharynx, that water bag edema that was kind of coming up along the arytenoids. Is that a fair description of what you thought you saw, Dr. Johnson?
Yeah, it definitely is. And I think at that point, we all agreed that this was a dynamic process. There was involvement in the lower airway or the lower part of the upper airway. We were in a situation where we were going to have to intubate this patient at that point.
Yeah, I think that's fair to say. And so as we're like, okay, now we got to, cords are right there. They're moving beautifully. Thank you, ketamine, because he was largely disengaged at this point, the patient at a mg per kg, but they were moving. He was breathing spontaneously. And I used that 4% saline to anesthetize the cords. And this is something that I've thought of. I've done through these drills constantly and in iterations. And I thought that would be a valuable thing. That led to a lot of choking, a lot of gagging and coughing from the person, because that working port is not a very good atomizer. It really is just a direct line. So this was pretty much just drips of 4% lidocaine. And two, it's going, we're right on top of the cord. So that's going into the airway. And so that led to coughing, choking, movement of the patient, and me losing visualization, right? It's one of those ones where if you ever, are doing these and someone coughs or swallows and it's suddenly a tornado in there of pink and foam and froth. That's what happened in that case. We were patient, everyone very lucky, or it was good in that once that settled and the patient came back to the normal sedate rhythmic breathing, there was still visualization of those cords. So able to pass through the cords. We had our team prepped with additional ketamine and a paralytic. And I believe actually we're like, okay, we're moving forward. Go ahead and give that additional ketamine. I'm now through the cords. Let's give that paralytic. And we were able to keep the patient still and steady until the paralytic was fully effective. The patient's airway was fully secured. Came on out. Fantastic. High fives. That went well. But that would have been my biggest point for myself is if we're working in a sort of DSI or a situation like this where we're keeping the patient breathing on their own, that anesthesia of the cords, particularly in this fiber optics case, could have been fraught with failure or challenge and probably didn't really make a difference in addition to the other medicines they were actively getting or were about to get.
I can see where there's just this push to do that too, because if you follow any like airway guru, any podcast or sort of lecture on this topic, they're always hammering home, localization, anesthetizing as the key to success for this procedure. And I remember being in the room being like, yeah, let's do that. That's a great idea. And instantly losing that view, I think all of our hearts kind of sunk a little bit. We're like, oh boy, I hope that wasn't the only view we got.
Yeah, right.
But I think the approach of just securing the airway and then immediately giving that, topping them off with more sedation or giving that paralytic, that is really the best approach in that situation. So,
I appreciate that. Thank you for, reaffirming my preconceived notions going into it. And, these are challenging cases to go through. And we, in SimKit talk all the time about halo procedures or, never events, once events. And these could be that case. Actually, when, taking a step back, we did this obviously for angioedema. The other major indication in my mind, even probably more so, might be Ludwig's angina, right? Because in Ludwig's, your hypopharynx or your sublingual space is brought up and you have very little oropharyngeal region. You also have very little front of neck access. So that is a nightmare. So those two cases, Ludwig's angina and these oropharyngeal angioedema are why we talk about this and why we prep ourselves with the fiber optic scope to do cases like these. So I appreciate you taking the time to go through this case with me, Brett. I was wondering if you could give me kind of your summative thoughts, the things that you thought went well, things that you would change differently. I can add or subtract to that, and then we'll say goodbye to our listeners. How's that sound?
That sounds great. And again, thanks for having me, Jason. I would say there's not much I would really do differently. I think when we did that last little bit of lidocaine anesthesia and then losing the view was, I think all of us were in agreement that we should try to do that. And then instantly, I think all of us were like, ooh, that could have been really bad. But fortunately, it wasn't. And I think that just, you can do that 100 times and maybe get away with it. But in this case, it was just, it caused him to cough just enough that we lost our view. But as far as takeaways for me, I think it's more big picture stuff. So it's knowing, these patients can roll through the door at any time, and it can be in your standalone community hospital alone. It can be in the sort of scenario where we were in now, where we had extra hands, and it can be at, your tertiary center where your code airway is just one phone call away. But just knowing what you have available and being comfortable with those procedures and the equipment, I think, is the biggest thing. I've now worked in a few places where we have these fiber optic scopes, and I think it's really important that we all, if we have access to these, are getting some exposure and some experience manipulating that scope, and then in our mind's eye, really running through some of these scenarios that could potentially come through the door. Because there are certainly scenarios where you have the choice of doing a fiber optic or intubating the normal way with like a dynamic changing airway, in which case you can, look for like your classic laryngoscopy look, or with a video or even fiber optic assisted video laryngoscopy. But in this case, this was just that perfect storm where there was nothing going through that guy's oropharynx, like through his mouth with the tongue the way it was. And so an upright nasal approach was really the only way to go about this. And so being ready to do that and knowing how you would go about to do that, I think is the biggest takeaway for me. And just being fortunate that I work in such a fantastic place with great colleagues too. So
that was a great pat on the back at the end there. Thank you, Dr. Johnson. Yeah, I'm with you. I agree. I think we had the perfect storm of goodness, if you can, in the right direction for this case, where different providers, different time of day, different quantity of providers, and different recognition. And in fairness, we're highlighting weirdly ourselves, but we had an unbelievable team, right? We had great respiratory therapists that day. We had charge nurses that knew what to do, techs that could find the supplies readily. Like we got lucky in a good direction, right? Better to be lucky than good in some of these cases, but you can't succeed also if you're not well prepared. And so having the equipment, knowing the equipment ourselves, one thing that I like to teach our learners about is, these scopes and using them takes time and takes a certain degree of visualization and hand-eye coordination. And they say, well, it's a rare event, but if a young patient presenting with profound sore throat is giving me some of the signals for epiglottitis, but I don't really want to CT them, I've taken the nasal fiber optic scope and taken a picture of their perfectly appearing epiglottis and thrown it in the chart just to show that that's not the cause of this patient's disease process. You could do the same thing with these, like, I felt like there's a fishbone that got stuck or lodged right here. There's opportunities, paradoxical vocal cord dysfunction. There's a lot of other times where we can practice the skill and prepare ourselves for the case that Brett and I discussed. And so I think having that hands-on with your equipment, having that communication style, and we also, I think we're lucky in that, Brett and I have a similar kind of approach and demeanor to sort of a quieter resus room. And so that played out really nicely and well. But think about when you have a resuscitationist and a proceduralist, how communication is going to flow through the room. Ideally, having that one point of contact that you both can refer to, who can kind of, march out the orders for the rest of the team. Pausing and summarizing, like you said, we did that when anesthesia entered the room. That's very helpful. I actually think we did that like 3 or 4 times throughout the case. But those elements, the readiness with equipment and ways of communicating, I think are by far the most important. I don't know if you have anything else to say. If not, I can just kind of thank you for coming on. Does that sound good?
Yeah. Oh, that sounds good.
Sweet. Well, Dr. Johnson, I hope we have an opportunity to talk about another really cool case that we performed reasonably decent at least we didn't botch it and fumble it, one that has a good outcome. And
well, those
actually,
those would be good to talk about too, probably too.
That's true. Yeah. The ones where you fail are actually some of the best learning, right? For sure. But I'm appreciative of the fact that this case had a good outcome, but also had learning, right? That's really valuable for me. And if you would, I want to say thank you, Dr. Johnson, for joining us, and tell us if what's the endpoint of the patient? Have you followed up with them at all?
Yeah. So our patient walked out of the hospital 2 days later, spent the night, I think a day and a half in the ICU. I think he was discharged from the ICU. And the presumed cause was an NSAID. So no history of ACE inhibitor on board. I did end up giving him a C1 esterase inhibitor. I think our hospital uses Berinert. I'm not sure if I'm pronouncing that right. But at the time, he really couldn't mime any of his history, and we couldn't get a lot of it out. And so he definitely got the kitchen sink from me. But I think he had earned it at that point.
Yeah. If you're putting plastic in there, you get the kitchen sink. So yeah, it's interesting to find that root cause. We think and we get hammered with ACEs all the time, but NSAIDs has to be talked about and asked about because it's not going to be readily available in history. But thank you for giving us that info. I'm glad that we got a patient walking out of the ICU a couple days later.
Yes. Yeah, it was a good outcome. So.
All right. Well, thank you again for being on the podcast, and we'll have you on again sometime soon.
Awesome. Thank you so much for having me.